So I hope that helps you understand how we got from, National Bioterrorism Program, which was about stuff, to Hurricane Katrina, which gives us the Assistant Secretary of Preparedness and Response, which is where the vision for healthcare coalitions come from. That vision gets lost with the election. Takes a while for the new team to get on the ground. In 12, they roll out these coalitions, kind of align more with the CDC and what they're doing capability-wise. In 17, there's a harder line drawn on what a coalition is and stopping states from holding too much of the money back. And sometimes taking 6 or 8 months to get the money out the door.
Hi, everybody. This is Chris, and I've got some folks with us here today, but I think I'm just noticing the time. Hey, Al, what time is it?
I was looking at the clock as well, Chris. It is time for Readiness Rewired, a healthcare preparedness podcast. So let's roll, buddy.
Awesome. And Mike, you on board?
On board, and she's recording. Let's do it.
All right. Hey, we've got a special guest today, Carl Schmidt from a neighboring state. And Carl has a unique skill set and view of healthcare preparedness. And Carl, I know you've got a master's degree, and I know that you've also you're a certified project management specialist. But you want to give us a little bit more of your background, and then we'll jump right into some questions about in your scope of knowledge.
Yeah, well, I appreciate you guys having me on. I'm a retired firefighter paramedic, flight paramedic out of the Tampa, Florida area, and came into the state of Illinois and took over the Division of Disaster Planning Readiness at the Illinois Department of Public Health in 2009. So I had FEP and I had HPP and the SNS program. All those programs came together in my division.
Hey, Carl, some of our listeners are going to be like fairly new. So
Okay.
FEP and HPP and SNS. The first time that we use those acronyms, we like to let them know what those are.
Absolutely. Public Health Emergency Preparedness Program, which goes from the Center for Disease Control Prevention to the state health departments and then to local health departments. The Hospital Preparedness Program, which I believe they are transitioning to the Healthcare Readiness Program or something of that manner. Not quite sure right now. But Hospital Preparedness Program goes from U.S. Department of Health and Human Services to the state health departments and then to healthcare coalitions. SNS is the Strategic National Stockpile, and that's the program that delivers not only pharmaceutical countermeasures, but also much of the personal protective equipment that came out during COVID came through the SNS program. So that's the the 3 primary programs that lived in my house in Illinois. My last year, if people remember, Dr. David Marcosi was running the hospital preparedness program, and it was his responsibility to transition that program to healthcare coalitions. And I believed wholeheartedly in that move to healthcare coalitions, which are regional, essentially regional consortiums of healthcare providers with emergency managers, EMS, and public health around the country. There might be 4 in a state, there might be 8 in a state. It depends on where it is. But I really believed in that concept. And being a former paramedic, former firefighter, after about 3 years in state government, it doesn't move, right? You're used to getting things done. Instant gratification. It worked or it didn't work. I was ready to go. And I rolled out and started my own firm in 2012, B. Parati LLC. I'm based out of Springfield, Illinois. And I focused exclusively on healthcare coalitions and developing healthcare coalitions nationwide. Did a lot of publishing, a lot of policy analysis. We had really good people in the Assistant Secretary for Preparedness Response in Washington, which is in Health and Human Services. And it was kind of a neat time because they were on board with getting this right. I felt like I was out there kind of being evangelizing it, educating people, helping coalitions get it set up as nonprofits with their governance and things of that manner. So I did that until COVID. And then COVID, pretty much as we all know, things shut down, particularly for on-site consulting. I ended up on about a 2-year contract with the state of Illinois, doing healthcare logistics and fixing some emergency support function 8 planning, which is part of the national response framework. And then I rolled back out about a year ago, but focused more on project management, broader than just healthcare preparedness, broader than just emergency management. It's not that I won't work in that area. That's my domain expertise. But the project management professional certification opens doors throughout the private and public sector to do any project. You don't have to be the domain expert to run a project. So that's
It's
where I am
process.
today.
Gotcha. Well, that's really interesting. And B Parati, for those that are going to go looking for it, you do have links on LinkedIn,
Yeah.
and then just people can Google that BPARATI.
Yeah. Yep.
Yep.
And when COVID came, I shut down my website. All those expenses that go with running all that went away with COVID, and I have not brought them back, and I don't intend to bring them back. But everything I've published pretty much is on LinkedIn. I use
Okay.
LinkedIn publishing, articles, newsletters, infographics. They can all be found there.
And what does B Parati stand for?
Be ready. It's Parati's Latin for ready. So be ready.
Awesome. And that's where we are. So can we step back? I know those guys are trumping a bit to ask questions too, but the hospital preparedness program really came about as kind of a knee-jerk reaction to get hospitals ready for mass casualties and so on.
Yep.
And like 2001 or so?
2002, probably by the time it kind of got through legislation.
Okay.
And if I remember right, it was actually the National Bioterrorism Hospital Preparedness Program or something of that matter. It was very focused on that post 911 era.
And that was really for the first several years, and maybe some of that's still a legacy today. It was about getting stuff, get grant money, and then get stuff, stockpile stuff that then decades later were not ready, weren't in any good usable shape. And the struggle, part of Marcosi's stuff too, was struggling from an institutionally specific, how much stuff can you stockpile, to networking with other strategic partners and looking at policies and strategies and so on. Is that fair to say?
Yeah. It's interesting you say that, because you're right. When it was still the bioterrorism program, that survived through Katrina, right? Just hospitals. Here's money. The HHS, Health and Human Services, Assistant Secretary for Preparedness. No, it was actually the Health Services Resource Administration back then.
HRSA
would give the grant to the state health department, and they would essentially just, here, hospitals, here's this stuff. Here's the money. And I know in Illinois, when I came on, we were giving 125, 130 grants out of that program. But the first shift, if you remember, Chris, was after Katrina, Hurricane Katrina in 2005. So the response to Katrina, with the problems that happened at Memorial Hospital in New Orleans, and Memorial takes the brunt of it because it was so famous, but they were not alone. There were serious problems in long-term care facilities. If people remember the St. Rita's nursing home tragedy, that's another one to look up. It has a great book, just like 5 Days at Memorial is a great book for people in our space to look at.
Okay.
But coming out of that is when Congress passed the Pandemic and All Hazards Preparedness Act in 2006. And that dovetailed with the Post-Katrina Emergency Management Reform Act for the folks in emergency management, right? For the emergency managers. That program created the Assistant Secretary for Preparedness Response at Health and Human Services. And if you look at all the documentation that first year, that was '06, by the time the first assistant secretary got on board, Craig Vanderwagen, by the time he got on board and started to get his vision for what was going, it was the '08 election. And the Obama administration was finishing up. So his vision was healthcare coalitions from day one. You could look at all the original documentation. He understood. He had been on the ground, boots on the ground, in New Orleans or in Louisiana for Katrina. So it's not like 2012 was something out of left field. It's just that vision got lost in the change of administration to Nicole Lurie. If you remember, she took over as the second assistant secretary. I don't think she was against it. I just think it took them a couple of years to get their traction and get the right people in place. So that broader approach was supposed to start in '06, but I don't think we saw the shift until 11, roughly.
Yeah, and I remember when that occurred, and then, it gets passed down to the states, and then the states are, tasked with trying to construct what their particular needs or divisions would be for these coalitions to meet their own needs. And I remember in our state, they thought, a lot of geographical landmass, but not a lot of people. There's more pigs in this state than there are people. Yeah. So maybe 2 healthcare coalitions, I think, was the prediction for our state.
Yeah, well, and you all know as well as I do, they went a whole different direction in Iowa, didn't they?
And why was that? Politics, right? Politics and the stranglehold that I think that, public health had on the system and the process. Hospitals, we really didn't have a lot of say in it. We gave them our 2 cents, but politically, no, it was those individual county level public health entities that wanted to put a barbed wire fence around their funding. And instead of 2 coalitions, we ended up with what, Chris, 90? Something close 90. To that?
Yeah.
That was real effective.
I remember when you guys, Colorado was a mess. California was a mess. And I ended up doing a big piece about that. How many healthcare coalitions is too many? And it was interesting because Iowa, as you allude to, Mike, there was clearly some politics that the county health departments or the county boards wanted to control that hospital preparedness program money, right? And would that be fair to say in Iowa?
I'd say fair. Yeah.
And as we all know, government doesn't run healthcare in America. How did that translate for you guys, in Iowa? Were the hospitals engaged, or was long-term care engaged in those coalitions when they had that many?
No, I think, I'll jump in with an opinion too, is that there is a grant available, and as public health manages grants, it's like, well, what can we use this for to manage our daily operations, right? Yeah. So why would we want to divide the money up with more people and have more meetings and more steps? So let's just make 1 or 2 county coalitions, right? The understanding of what a coalition was left in individual determination. And like you said, Asper and Dr. Marcosi and all had these grand visions, rightfully so, of collaboration with long-term care, with clinics, with all healthcare providers to make it sort of a seamless partnership. But not to be.
Yeah, it didn't work.
So if you look at Iowa, it was clearly there was a political component. California had built their EMS system years ago at the county level. If everyone remembers the TV show from the '70s, Emergency, and Johnny and Roy, right? Those are county-based systems. So when the hospital preparedness program came along in California, they plugged it into those systems at the county level. So when California went to coalitions, they did exactly what Iowa did, but just for different reasons. They already had it set up, so they had single county coalitions. In Colorado, I'm not sure what they did or why they did it. They ended up with 23 or 25, probably politics of some sort. Texas, has got a lot, but it's a big state. So when you looked at population versus, it made sense in Texas. But the challenge is you want the healthcare coalition to be that neutral space, right? That non-competitive space. You don't want it to be owned by government. You don't want it to be owned by any single entity in the coalition. The
Right.
chair can't be from the, be mandated to be from the biggest medical center in the region, who's the 800-pound gorilla, and then give them the grant and tell them to build a coalition. That's very unfair to them, and it's unfair to their members. Because if you guys all sat in that seat of being the hospital in the larger hospitals, running your hospital's emergency management program or your systems, to try and have you then do long-term care and do the rest of it will be highly challenging.
You know, the other thing that, Carl, being from Illinois, I had hospitals both in Iowa and Illinois, and talking about grant funds, Mike and Chris and I have talked about it many times. And before we started the podcast, you mentioned our buddy Troy Urbantrout, who was on episode 9 and is now down in Texas. But it was amazing to me how the grant funds back then were being used, because in Illinois, when I went down there to the regional meetings, they had this big warehouse and they had all this equipment and response stuff. And I went, this is really cool. I mean, and this is something that's effective for the tornadoes and the fires and all the other things that they would respond to. And over in Iowa, we use the money differently. And I'm not judging and saying one's right, one's wrong, but I know that today we've got very little in Iowa for coalition or region response equipment. And yet down in Illinois, and especially in Region 2, I can't talk about all the regions, but in Region 2 you're familiar with, it's pretty impressive. And they continue to build and maintain and support that stuff. So when a disaster happens, they've got a little skin in the game.
Yeah, Illinois, kind of like California, the same issue. When they built their EMS system, they built a regional kind of EMS system. I want to say 11 EMS regions. So when the National Bioterrorism Hospital Preparedness Program came along, they did what California did, but instead of at the county level, hey, the 11 regions, you're going to get this money. So that model made sense for that original program, because the hospitals were getting individual money. The Regional Hospital Coordinating Center, which coordinated EMS and coordinated disaster response for the region for hospitals only. It worked and it made sense. But when we got to coalitions in 11 and 12, it got contentious because coalitions were supposed to be broader, right? They were supposed to bring in more partners. And those hospitals have a lot of political control. The Hospital Association found themselves in a hard spot with the smaller hospitals versus the bigger ones. But so Region 2 that you're talking about, Al, that Troy ran, they were one of only 2 coalitions in the state out of 11 that had a robust warehouse and response capability. The only other one is down in Region 5 in Carbondale, Southern Illinois. And those are the 2 that had capability. The rest of the state didn't use the money as strategically, really didn't, I don't believe, had the long-term effect that it should have had. And quite frankly, it's probably the worst in the Chicago region. They have 5 healthcare coalitions for 9 counties. Everyone's got their fiefdoms, and they never broke that up to do what they did on Houston. Troy went to work for SETRAC in Houston.
Mm-hmm.
Well, they have 11 million population in one healthcare coalition. I don't know how many counties it is, but they've got a management structure and it's very efficient. Versus, when they do have a response and they do have a problem, they operate as one. You go into that Chicago region, they operate as 5. And then forget the 5, Chicago has their own. They're separately funded, like a state. Mm-hmm. So Chicago has one, then Cook County and part of Lake County has one, where literally, depending on what side of the street you're on, is depending on what coalition you're in. So, there are challenges with coalitions nationwide still. It's very, very frustrating not to see more success stories.
I have a question about Region 2 in it. Now, I'm from Peoria area myself. I'm an Illinois boy. And so how were they able to develop such a robust response capability? And I went down to that warehouse. Al took me down there, and it was pretty amazing how many assets, how many resources they have. They had personnel. Did they get more money than everybody else? I mean, it's all about money when you start trying to build capability. And if the other ones didn't build it, did they not get as much money? Did they not manage their money and prioritize their money? How were they able to be so successful?
The statute of limitations has gone by, I believe, so I think I can speak about it.
Uh-oh.
Great.
Don't want to open up a can of worms or anything, but
Yes, we do.
I mean,
yes, we do.
if they did so well, how was that possible?
Well, there's a couple things. One, Illinois, like most states, has a population-based funding formula. So each of the hospitals in the state would get a certain amount of a base. And then the 11 regional hospital coordination centers, or 10, whichever it is, got a larger base. And then there's a population multiplier on that. My understanding of what went down in Peoria or in Region 2, and Troy could answer this question better, because Troy, I believe, got hired when they terminated some people that ran that program for the first 4, 5, 6 years, whatever it was. They made a lot of purchases that might be considered prohibitive in a grant agreement. But there wasn't any oversight, right? Remember that money's flowing really fast. The state's not ramped up really to oversee it. They're just handing money out. And I believe that's one part of it. All right. So things were bought that shouldn't have been bought, like what, a fatality management 18-wheeler and a mobile operating room, that kind of stuff, right? They have all that. You're right. It's impressive. And they have the ability to staff, which is even more impressive.
Yeah.
So I some of that went on early on. The dollars were big in those early days. So while the other regions were wasting their money on whatever, they focused and decided as a region, I believe they pooled their money more than maybe some others did. But again, they focused their dollars. It was big dollars for those first 4 or 5 years. And I don't think that there was really much oversight on what you could buy and not buy with a grant. So a lot of things got bought. Some are around 05, 06 is my understanding. Someone did an audit. Some people got let go, but you don't have to give the stuff back. And so they've got they had a solid foundation. I can tell you in the years I was running the program and the years that followed, when Rawls, my boss, was the deputy director for preparedness and response, whenever you had what was called carryover money, extra money in the grant at the end of the year, and you're looking for shovel-ready projects that are meaningful, a lot of that money will go to Troy and the team at St. Francis that ran Region 2, because they had a capability and they were really, really good. So I think, they were able to maintain it better, and they were able to actually expand upon it using carryover dollars in those years that it was available. Kind of a three-pronged thing. The 3 prongs got them to where they are.
And I think they had Troy and the group, the Region 2, had really good support from OSF St. Francis, which was,
Yes.
And I to this day has tremendous support down there for the region and everything happening at that warehouse and at that RHCC, the coalition site.
Yeah, they're not your typical hospital. I mean, they're a heartland hospital, right? But they're a major medical center for a large geographical area. They're one of the only ones around. I think they've bought 90% of the hospitals in their region they own now. but even before that, you're right. It's owned by the Sisters of St. Francis,
right?
I guess would be it. Yep. They have very much a philanthropic mission. They believe it is their responsibility to care for the community. And you don't get that in the big urban areas, not in the same way. So yeah, they have a lot of support.
So Carl, we got to pivot in, kind of by 2012, and there was a call out to, rethink your state's concepts of healthcare coalitions. And I think a
Mhm.
handful of years later, it was called out again that, hey, you guys need to get it together.
Yeah.
Kind of fill us in what was going on for the next 10 years or so there.
Yeah, and if you ask me why I'm transitioning away from working with healthcare coalitions, it's because of that history and watching it, and it's so hard to watch something not going well when you know it's important, it could be better, and you've invested a lot in it, not just time, but gave up, a lot of money to try and help make that happen. If you look at 12, okay, Marcosi gets the green light to push the coalitions. It comes down, still somewhat loosely defined. If people might remember that have been around, the CDC in Atlanta for the health departments has the public health emergency preparedness capabilities. So 15 capabilities that health departments need to meet. During that time, Marcosi and the folks at the Assistant Secretary for Preparedness Response at HHS worked with the CDC really tight. Marcosi got along with the woman who still runs the program at the CDC, Chris Cosmos. Chris had come out of Chicago Department of Public Health, a boots on the ground nurse, got the program. They decided that they were going to dovetail healthcare capabilities with the public health emergency preparedness capabilities. So the public health capabilities came out, I think, in 11, maybe it was even 10, the 15 capabilities. In 12, the first healthcare preparedness capabilities came out, and I think there were 8 or 9 of them instead of 15, but they were numbered the same as the CDC's. So if they had fatality management was capability, let's just say it was 15 for the CDC. Well, then that was capability 15 for healthcare. But the capabilities look different, right? And it seemed to make sense. So that was the original philosophy. Let's get public health and healthcare on the same page as we build these coalitions. And they told everyone, okay, you need to have emergency management in your coalitions, and you need to have public health in your coalitions, and maybe EMS, you should probably have EMS, and then the other healthcare people, right? But it was very loose. It didn't define in those capabilities what a healthcare coalition was or who had to be in it. So from then until roughly 17, a lot of people just did what they were doing before. Not a lot changed. And I think that's where everyone felt like, man, we're just not moving. The shift came, a couple things went down. In 13, it was late 12 or early 13, Dr. Marcosi left and went to the Center for Medicaid and Medicare Services, where he actually got to work on what's now known as the CMS Emergency Preparedness Rule. So he leaves, and a woman, if you remember, Melissa Harvey, came in to run the hospital preparedness program. Melissa, very sharp lady, had watched. I don't know if she had been Marcosi's deputy or not, but she was able to watch the malaise, the fact it wasn't moving. And so she tasked her team with a complete rewrite of the capabilities. We're going to separate from the CDC. We're going to do our own thing, not because we don't believe in what they're doing, but it was a bad marriage, right? We're trying to make these capabilities work with those. So the healthcare preparedness capabilities as we know them today were released in 2017. And those were focused on building a coalition. It got into bylaws, your governance, your jurisdiction, policies, procedures, and it had mandatory membership for coalitions. So and at the same time, there was a shift in the way funding worked. So until that time, they would send the money to the state health department, and the state health departments were supposed to start funding coalitions, but it really wasn't enforced. So a lot of state health departments kept kind of doing what they wanted to do. In Illinois, they kept funding the major regional hospital coordination centers. And quite frankly, they prepared hospitals really well, but they really didn't engage anyone else. They invited public health to their meetings, and they invited, EMS and emergency management. But they didn't really function as a coalition. What Melissa did, in a pretty bold move, she said, okay, state, we're going to give you this money. Too many of you are keeping way too much of this money at the state office trying to run this top heavy. She said, you must get 80% of the dollars we give you must go to your healthcare coalitions. Get them downstream. And I think they said if you don't get it out the door in 60 days, there was a date specific. She wanted the money downstream to these coalitions that are now defined in the healthcare preparedness capabilities. And those were capabilities of 2017 to 2022. They put an expiration date on it. I don't know if that makes sense, but they did. And when you do that, people expect new ones. And that's another story we'll get into in a minute, because we still don't have new ones. But the coalition started to coalesce and become a little more what they should be. And I think that's probably about the time Iowa got the pressure to fix what was going on there. Somewhere around 17, 18, 19 by the time they rolled it out. Same thing in California. I believe the 5-year cooperative agreement, which is the money from HHS, literally gave criteria. It said your coalition must have at least 3 hospitals in it, or it's not a coalition, right? So that took those counties that didn't even have a hospital from getting hospital preparedness money, which was happening all around the country. Right. So she did a really good job of, one, defining the coalition. And she said, it's not a healthcare coalition if it doesn't have, I believe it was 3 hospitals, EMS, public health, and what's the third one?
EMA?
Emergency management. Emergency management, public health, EMS, hospitals. And of course I said, well, Melissa, that's not a healthcare coalition, that's a hospital coalition. Where is long-term care? Where's home health? Where are the other pieces? I don't know what the politics were. It's complicated writing a grant that works in Wyoming and also works in New York City. But they left it at the core 4. So what we saw was that coalitions did formalize better, beginning in 17, but they most of them didn't go beyond the core 4. So really for the hospitals, it was really the same thing they had before, except they more aggressively invited emergency management, public health, EMS, and they included them in their bylaws and they gave them a vote. So that transition in 12 was well-meaning. I think Marcosi's departure, just as we talked about with Craig Vanderwegen's departure in 08, right? It takes a couple of years for things to get back on track. And so we didn't do real well in 13 and 14 and 15 and 16. It formalizes in 17, but it formalizes at the core 4 only. And there was also no mandate. And I understand this. In my world, the healthcare coalition needs to be independent. It can't be owned by any one entity in the coalition, right? It can't be owned by the health department. When I say owned, whoever gets the grant is the owner. Right. Because legally, every single thing that's bought, yeah, sure, they're a nonprofit or sure, they're government. But when that coalition votes to buy something, who owns it? Whoever gets the grant. And if the coalition breaks apart, they don't have to distribute it. They can keep it. Unless the state did a really good job in their grant agreement that gives rescission capability. And I only know that because we lived it in Illinois, and I had to work with lawyers to build a rescission capability when some things changed because we couldn't get anything back.
Yeah.
So I hope that helps you understand how we got from, National Bioterrorism Program, which was about stuff, to Hurricane Katrina, which gives us the Assistant Secretary of Preparedness and Response, which is where the vision for healthcare coalitions come from. That vision gets lost with the election Takes a while for the new team to get on the ground. In 12, they roll out these coalitions, kind of align more with the CDC and what they're doing capability-wise. Didn't define them well. In 17, there's a harder line drawn on what a coalition is and stopping states from holding too much of the money back. And sometimes taking 6 or 8 months to get the money out the door. So that's where we are pretty much today. I mean, how are you guys feeling about coalitions today? I mean, Iowa made a big shift. How are you guys doing?
You know, I remember when we originally proposed that our 6 preparedness regions, which we originally had under HRSA,
Yeah.
would just be converted to coalitions with some tweaking of the boundaries and things like that to meet the criteria. And we were told at the state level, no, they throw that out, that idea. A region is too big to be a coalition.
Yeah.
And this is where me and the bureau chief then started having, unfortunately, a conflict. And I don't think that conflict ever went away. They did, like I said, you know, when you said they kind of came down in 2017, says, okay, you got to make some changes. They then drew the lines for everybody. And what they did was they took an assessment. They took some data that they pulled from ambulance trip sheets on destinations. And they tried to build the coalitions around transports and transfer patterns, right?
Yeah.
And say, okay, here's a coalition. This seems to be, you know, where all of your transports tend to acquiesce around this facility or these 2 or 3 facilities. Therefore, they're going to be the center of your little coalition universe. So that's the way they try to do it. And I'm an EMSer. Chris is an EMSer. So, you know, to us, it sounded like a better way to try to draw the boundaries than the political way it was done before. Did it really work out that well? Probably not as well as it could have if they looked at other factors. It seemed to me, and then you guys can chime in on how you feel about it. The last years that I was on the receiving end of preparedness dollars, my boss just looked at me and said, don't bother. There's not enough for us to worry about. I think there was like, you know, maybe for a place our size, 850 beds. I think we were eligible at that time for about $7,000 a year in grant money.
Why do the paperwork?
And it's like, that's not even worth the paperwork for me to sit there and spend my time doing it. But then, you know, it seems like over time there was money left at the end of the year in the coalitions, and Al and Chris probably know better than I on that. And then what's done with that money? I don't know how the money is balanced out now, but I know my successor who's in there now, it's better. There is more dollars available to support a program. And so now it is more worthwhile. But that's about all I can comment. I will leave it to you guys.
Yeah, and I'm not going to add much to that being away for 2 years, even though I have a little bit of touch yet with Genesis. I've kind of really, Carl, like you, it's like, you know, I want to do some emergency preparedness stuff. I want to do some exercises, drills, but that coalition stuff and the service area stuff, I leave that to the people who are getting full-time, you know, hours and stuff. Right. So I have really backed out of that stuff, but I don't see it as much of an improvement.
You know, what I see is a legacy of the process being transactional, not transformational. And it was really intended to transform coalitions. Yes. And the problem is that so many of them that are used to dealing with grants, and they end up being by default kind of the ones that are managing the grants, are about the transactional side and not the transformational side. And so when you look at clearly lessons learned all along the way, from Katrina to the Trade Center collapse, Sandy, and so on. Sandy. You know, and then we've had derechos and things like that. People tend to take a transactional, you know, again, it's just embedded that we need stuff and we need to do better at what we do now, as opposed to re-envisioning what we're trying to do. And I think that takes some real political will, for one, and then some really savvy understanding, which you're providing here now. I think the new or recent emergency managers that have ascended to places way too many of the hospitals are people that have don't have a sense of the history and of the intention. And again, it's managing it day to day. Yeah, I have a budget. I need to buy stuff. This is what I had last year. Why would I zero all this out and start over again? Right?
Mm-hmm.
So I think the other thing that we clearly want to get from you, if we can, is who in your mind did it right. I mean, there's some people out there that, and we're referring to OSF and Region 2, but clearly I think there's some people in Tennessee, there's some people in Virginia and Florida, and maybe if we can kind of cite some of the people that are doing well or did it really well, those that are looking for answers know where to make the first stab at the, at research.
Yeah, it's you almost have to look at it. There's a fork, right? You've got mega urban coalitions with a lot of money, a lot of support. And then you've got more rural coalitions that don't get as much and maybe a little more challenged on the resource front. But I will tell you, I've seen success stories in both. Success looks differently in Chicago than it does in Jackson, Tennessee. I would say if you're looking at the larger coalitions, healthcare coalitions, the Southeast Texas Regional Advisory Council is clearly the gold standard, right? Now you're talking Houston, huge population, 20-something counties covered, disaster-prone area, a state that prioritizes preparedness, as Troy Urbantraut was saying, where they're literally getting state money on top of federal grants. But their ability to assist with getting boots on the ground and dealing with surge capacity issues is pretty impressive. They do it 24/7, 365. Now, Texas had a regional structure when the money came out in 2002. So they were already set with a system to plug that money into that had these regional advisory councils, is what they call them. And those are independent. They may use a fiduciary. Some don't. Some of their own nonprofit corporations. Some might use a fiduciary, but they've built a system whereby they operate very independently. Their boards make decisions. Their members make decisions on what they're going to do and what they're going to prioritize. Another one that's been really impressive that moved to nonprofit quite a bit later, Northwest, it's Washington State, the Seattle area. You have Lori Upton runs SETRAC down in Houston, and Nora, now I can't remember Nora's last name, runs the coalition in Washington. They have done a good job. They're independent. Just watching them on LinkedIn, very progressive. If you look at smaller coalitions, I'll give you just two. The Near Southwest Preparedness Alliance in Virginia. Now, they recently merged with the coalition next door, and so they've changed the name. But they have been extremely progressive from day one. And again, they're a case where they do use a fiduciary, but they got profound independence. And they are really, really out there and progressive. They have a 24/7 call duty officer, 365 days a year. Now, you expect that out of SETRAC in Houston. You expect that out of, what's going on in Washington, in Seattle. But you don't expect that rural. And they've had that for well over a decade. Another one is called the Watch Coalition in Tennessee, out of Jackson, Tennessee. Predominantly rural, but man, those people galvanize around each other. They care. And I worked with them early on to build governance. We built their bylaws and went through policies and procedures. And watching what they've done with it, they're a good example of a coalition that has run the gamut of the financial nightmares of using fiduciaries. So they initially their fiduciary was a Jackson County Health Department. Great health department, really well run. But government agency, strict government procurement rules, a lot of bureaucracy. So if they wanted to spend more than $5,000, well, the county required them put it out to bid for 30 days, have a 30-day post-bid, just all these things that would become a bureaucratic problem for them. So they said, all right, we got to do something different. And of course, I was advising them. I said, go 501c3, go independent. You guys are sharp enough to do that. It's a big step. So James Fountains, our executive director, has been going way back. The board decided we're going to go with the hospital. The major medical center has a foundation, a 501c3, and they manage funds for many charities. So they said, well, let's go with them. They get with them, and they got into the same problem. But, part of the problem is, again, who owns the stuff, right? And will someone play hardball when you break away? That was not their concern in Jackson, Tennessee. That doesn't tend to be a rural problem. Rural areas don't do that. Rural facilities don't do that. That's an urban problem, right? That someone's going to try to hold on to all the stuff if you move the grant. But so the foundation had a whole set of bureaucratic policies and procedures. They've been running grants for nonprofits for 20, 30 years and had some problems. So you added more rules and more rules and more rules. They were like, man, we can't get anything done. They sent 6 people to the National Healthcare Preparedness Conference. And afterwards, when they turned in the receipts and everything, the foundation said, well, you're not allowed to send 6. Our policy is you can only send 2 or 3 to a conference, right? What? And they wouldn't process the reimbursement. So there's an example of they were with government, it was a problem. They go with another nonprofit as a fiduciary, it's a problem. So they're now a 501c3, have been for 3 years probably, doing really great things, moving towards some models, potentially doing fee-for-service work. They do a really nice annual conference. So watch Coalition of Tennessee. Near Southwest Preparedness Alliance, just recognize if you go to look for them, it's called something else. South Central, maybe. Preparedness Alliance of Virginia. SETRAC in Houston. And the Northwest something Preparedness Coalition. That might be it, Preparedness Coalition in Washington. That would be my 4 I'd point you to.
So just getting through COVID, they're starting to settle down a little bit. Got to get ready for the next one because we all know there'll be another one of those, and God only knows what else. In your mind, with all of this history and all the lessons we should have learned about this whole process of development of coalitions and response capability and whatnot, where do you see the best what do you see as the best path forward for, let's not look at the big urbans. Let's stay fairly rural since we serve mostly the Midwest here. Where do you see this going? Where should it go from what you've learned, what you've seen? I know it's not all solutions fit, right, but what do you think is the best path forward to kind of get things on track and where it ought to be in a better footing?
First off, I'm a proponent of coalitions. I believe the only way you're going to get 100 competitive healthcare facilities that are all trying to beat each other in business to work together, there's got to be an independent middleman, right? So if you are a state like Illinois that's sending the money to the largest hospital in the region and saying, run your coalition, and Illinois is not alone. I'm not picking on them to pick on them. It's all around the country. We're seeing that. Get it out of there. Get it to a neutral entity. And I know, again, let's get to rural Wyoming or even rural Iowa, that it may not be as easy, right? Who is that rural entity? What is that nonprofit that can do that, right? Can you do it through a regional United Way chapter, through a regional Red Cross chapter? I mean, anyone can serve as that. In the ideal world, you would be your own independent 501c3 organization because you could be nimble. You could be nimble. As we all know, when disaster strikes, major disaster, take COVID, take Hurricane Sandy, the federal government will suddenly start pushing money to the response through the emergency management agency in the states or the public health department or both, right? And they're going to be looking for a place to get that money fast to get it out of the state procurement system and the politics. And if you're independent, you can be a recipient of those dollars. If you're not, I mean, are they going to send it to the largest hospital in Chicago? No, everyone else around them is going to have a problem with that. So I do think there's a getting yourself independent. And if you can't do it corporately, do it through your governance, your bylaws, and the way they are written so that your fiduciary understands you are independent, that you do not live by their policies and their procedures, that type of thing that gets in the way, right? So you don't run into what the Watch Coalition ran into twice before they finally went independent. Now, there are a lot of coalitions that have really good fiduciaries, and it works very smooth. Near Southwest Preparedness Alliance still uses a fiduciary as far as I know. They may have made a shift in the last 2 or 3 years, but a very good relationship. It worked very well. Again, more on the rural side, less than likely you're going to have an issue. So I'm not saying it has to be independent. But the other thing that has to happen is these coalitions have got to move beyond the core four. Because right now, it's a hospital coalition that we're inviting emergency management, public health, and the EMS guys, if they can make it over. I mean, EMS, it's a hard discipline to get engaged because they don't have a bunch of extra staff sitting around. They can't take units out of service to attend a meeting. But I would say there are 3 pieces that have got to be added to every coalition in the country. Give me a core 7. I understand that you can't do all 17 provider types in the CMS emergency preparedness rule, and you may not need to. But if you don't get long-term care in these coalitions, if you don't get home health in these coalitions, and you don't get dialysis in these coalitions, you're never going to fix med-surg. Because when you need to decompress a hospital, you need to send them home, you need to send them to the long-term care center, and they're probably, if you've got a renal patient, they're going to need dialysis without going to the hospital. Those 3, and this, I argued this with Melissa Harvey in 2017. It was like, you've got to have these 3. What is your thoughts on that? I mean, some people will talk
Totally
about community
agree.
health centers
Yep.
and all these others. I get it, but
Totally agree, because I had dialysis centers under me for preparedness. We just built and put together a long-term care, well, not long-term care, more short-term rehab hospital, and had just now acquired another one. So you have to have a place for those patients to go
right.
to decompress the hospital. So you're absolutely correct on that. And I can't imagine how you could make it work without those 3. Home health care, that's a tough one. We do have home health as well. And so wrapping all of them up together and getting them to come to these coalition meetings, that's a challenge, but I don't disagree. What do you guys think?
Yeah, I was going to say the same thing. I totally agree. And I think the first challenge in that, and we're trying to do it where we are, is to get them to understand that they should be a part of, because a lot of people will, look and go, oh, that's not for me. Yes, it is. We need to give you the why. It's telling them the why you need to be involved, and then the benefits of the partnerships that can come out of it. Because I think anybody in our coalition would say, yeah, Carl, we agree with you, but it's an uphill battle to get them to understand their piece in the puzzle.
What's interesting? If you go back to 2017, when Melissa Harvey made all these firm changes in the program, significant changes in the hospital preparedness program, there were things coming together at that time that made me feel like, man, we're finally going to get this right. And that was the CMS emergency preparedness rule. Marcosi was over there able to kind of keep an eye on that, be talking with ASPR. And they also had something else going. They had a interagency grant development. I don't know if it was a committee, but FEMA, CDC, and ASPR would meet together as they were developing their grants for the coming year. So I said, man, the CMS emergency preparedness rule, to me, if they can get this, and if you look at the rule says, I believe it's 80 times in the rule, it says, we strongly encourage you to engage your healthcare coalition, right?
Yep.
Why'd that end up in there 80 times? Because Marcosi was over there and they were saying, look, these two things dovetail. We're going to get long-term care to the table finally. We're going to get home health to the table finally. Like, we're going to get dialysis to the table because they've got a regulation now and they have to do this. So we ended up in that rule, right? But then what did Melissa do? I don't know what the politics were, but she made the core four. Once she said the core four for a coalition of these four, she killed it. She killed, because now the coalitions didn't have a reason to fight the fight, make the push, right? Yep. You had finally a long-term care going, well, where do I find this healthcare coalition? They would go to the CMS website. It would say, here it is. They would click on it and they would get a name and a number and they would call, and people wouldn't call them back and people would blow them off. The coalitions didn't really want them there. Most didn't. I'm not saying all, but most didn't want them there. That's a lot of work. Now maybe we're dividing the money up further. They still thought, you know? So we really had an opportunity with what CMS was doing, with what ASPR was doing, and the disconnect came in the core four in my mind, and not make it at the core 7 or the core 8.
Agreed. Hey, Carl, what do you think about adding mental health?
Oh, good God, yes. That's what I said, core 8. If I had an 8th, it would be community mental health. Absolutely.
Yeah. Go ahead. Well, I was going to say, and then there's, the two other groups that are strategic, but I'm not sure they're independent enough. One is pharmacies, and the other is dispatchers and communication centers, right?
Yeah.
But again, they tie into law enforcement. But yeah, lot of work and long ways to go. Hey, I just want to be mindful of our time.
Okay.
Maybe we can go around one more time if there's questions that we haven't answered or points to make. Al?
Yeah.
Anything else?
Yes. Thank you, Chris. Very quick one. And Carl, just with your finger on the pulse, you kind of mentioned we've been talking about federal grants, the HPP, the FEP funding and stuff. I heard a rumor the other day at a meeting, and a pretty reliable rumor that said there's going to be funding cuts coming at the level of 9% because the money's being diverted and used for border security. Now, politically, I'm not going to go there either way. But when everybody heard the funding cuts of 9%, you could see the pucker factor coming in a lot of people, because 9% is a lot of money. And I didn't know if you had heard rumblings or anything on that.
No, and it doesn't sound like it's something that could be easily done. Congress would have to do that, right? So they did a continuing resolution that carries the HPP program funding through what is the end of the grant year now? June 30th, I believe?
Yes. Right.
All right. So we know that is in place. You have your funding through June 30th. What happens after that? Congress is going to have to make a decision, because people are go ahead.
No, I was going to say, and you're exactly right, because they were talking about, we're going into July 1 of this year, we're going into a new 5-year plan. It's the first 5 years is up June 30th of this year, and we're going to go into that next 5-year plan, and that's where everybody's hearing about these 9% funding cuts coming. And they're looking and going, wow, the things that we've spent money on, the things that we've had to support prior, it's going to be challenging. Yeah.
Well, there's a difference, and I recently kind of wrote about this, between authorization, right, and appropriations. So authorization is where our bigger concern is right now. The Pandemic and All Hazards Preparedness Act, as amended twice, expired on September 30th of last year, I believe is the date. It expired. So we're not looking at reauthorization right now. We're looking at resuscitation. The program right now is pulseless, right? The authorization for the program. Now, if the law worked, if the law was followed the way it should be, a program that's not authorized can't get appropriated, right? We're in this window here, and I'm very curious what's going to happen effective June 30th. If they don't reauthorize that program by the 30th, and we start a new fiscal year, can Congress appropriate a program they haven't authorized? That's the wild card right now. So if that's the case and they can't, 9%, you'd be begging for a 9% pay cut versus 100.
Wow.
Right? Because think about it. It's the fiscal year started July 1st. So the budget that we're under started July 1st. The new grant year, or was that the grant? The grant started July 1st, right?
Grant, right.
And the new fiscal year started October 1st. So the money started flowing before the program expired. So apparently they get to keep the money going until the end of the budget year, the fiscal year. For the first time, the reason I've gone on and got my project management professional and other certifications, and I'm hedging my bets toward other business, is I'm not confident in resuscitation. The politics of a law that's the Pandemic and All Hazards Preparedness Act, that name alone is a red flag for 30% of Congress right now. Minimum, right? Right or wrong, doesn't matter what's in it. They need to change the title if they're going to bring it back. But then the question you get into is, okay, so we do get it reauthorized or reestablished or resuscitated, whatever you want to call it. We get that. It still has to be appropriated every year, right? Congress only budgets 1 year at a time. Doesn't matter if there's a 5-year project period for the cooperative agreement. If they don't attach money to it, it's not going to matter. We're $33 trillion in debt. We're finally getting a kind of a conservative push on the fiscal side we haven't seen in a long time. You know what? The politics have been a lot about social conservatism, but the fiscal side of it, really the last 10, 15 years, you know, probably since the Obama administration, I would say, that's the last time we worried about the fiscal side of it. So we're at a point where it's going to matter. And how much do they have to cut programs like this to make a difference in the federal budget? What, 80% of the budget is non-discretionary, right? It's defense or non-discretionary, roughly 80%, 70, 80%. They're not going to touch that, right? That means cutting Medicare. It means cutting Medicaid. It means cutting the military, those type of things. Such a small percentage of the budget. We live in that small percentage. And that's my worry. That's what my worry going forward is. We've got a law that has a political connotation to it, right or wrong. The Hospital Preparedness Program, Public Health Emergency Preparedness Program are tucked into that law. That's how they're authorized. Mm-hmm. So even if we get through authorization, with the budget situation we're in and the cuts are going to have to come, whether it's for border security or whatever you want to say, it's a scary path forward.
It is a scary path forward, and that's kind of bringing this round to what Chris is saying with our time.
Yeah,
I'm a bit concerned about the future, and what will be our posture, what will be our healthcare preparedness, our readiness to deal with the next big healthcare issue, whether it's a pandemic or whatever. It's kind of scary.
Yeah, you know, and it's interesting with the CMS emergency preparedness rule, and of course you've got accreditation that kind of dovetails with that. I feel like on campus, individual facilities are still going to do what they've been doing. Now, as Troy alluded to, how effective is that? You know, not as effective.
It's a checklist.
As it could be. Yeah,
it's a checklist.
It's a checklist. Yes, as he did, and I couldn't agree with him more. But there is some sort of a semblance of regulation there. But without this program, without coalitions, there is no broader piece to bring long-term care, hospitals, home health, emergency management, public health. There's no incentive to get them working together. That's our challenge.
Yep.
And that's probably a great place to leave it this session, and maybe a future session can talk about readiness reimagined, and we'll bring you back to be a part of that conversation. But we certainly appreciate your time. Mike, some comments and reminders for our listeners?
Yeah, I want to echo. Thanks for showing us the past and what potentially could be the future, Carl. got a lot of thoughts there, a lot of things to think about.
Thanks.
So we want to make sure everybody comes back and sees this again. Remember our email, readiness.rewired@gmail.com. We want to hear from you. Make sure you click that subscribe button, ring the bell so you know when we post another video, and we sure hope to hear from you. We want to know if you think we're doing a good job, giving you content you can use. Tell us if we really suck and don't bother to come back, but we sure hope we put something out there that you like. So hope to see you again.
Take care, guys.
Yeah.
Thank you, Carl.
Hey, and please go to LinkedIn and look up Carl Schmidt and B. Parati and he's got 60 plus articles and some real insight for you guys to consider. So avail yourselves of those resources.